Hi everybody, welcome to the diabetes lecture. We're going to spend the next couple hours talking about different types of diabetes, specifically focusing on type 2 diabetes for the most part, but we'll also cover, of course, type 1 as well. I'm not really going to talk a lot about gestational. Actually, I deleted the slides from this PowerPoint, and we'll talk about that a little bit more during OB, just because I don't want to really get caught up in that at this point. Type 2 diabetes is kind of complicated as far as the regimens go, so we'll get there and we'll kind of walk through it. But first, let's talk a little bit of background about diabetes and glucose metabolism. So your body, of course, takes in various starches and sugars that get metabolized ultimately into glucose. The goal of the body is to break everything down into individual glucose molecules, and it can utilize those for cell energy, or that can be stored as glycogen. And then, of course, that storage of glycogen can be released when the body needs to access those energy stores. Now, if you get too much of this and this process gets, or too much glucose, I should say, and this process gets out of sync, you can end up metabolizing those into different things, like into free glucose. High amounts of free glucose can get metabolized into or get converted into fatty acids and things like that can contribute to various other types of metabolic syndrome. So, but glucose in itself, unchecked, can also have a lot of issues for various systems in the body, and we'll talk about those as well. This just shows you essentially a little bit about what I just said. So glucose is, of course, your energy ready. So if you're measuring blood glucose, that's what you're measuring, is what your body has available. And at any given time, everybody's body should have a certain amount of glucose circulating in it because it needs it. Our brain needs it. Our muscles need it. We need to have access to that energy source. So you should never have none. And of course, if you're hypoglycemic, that can be a really deadly complication potentially. So anyway, you can convert to glycogen, which is a storage of energy in glucose form, which can ultimately get converted into fat, and fatty acids, which are ready energy. So it all kind of works together when it comes to using glucose in the body. And we'll talk about some of these items when we talk about the therapies. Complications can really be any major vascular system, and a lot of times we're talking about microvasculature is going to be what people mostly see as the problems contributing to long-term uncontrolled diabetes. Think about glucose being a small molecule, of course, and at its normal levels and within normal limits in a standard person, you aren't going to have any issues having circulating glucose. However, if you get a lot, I had somebody explain it once to me that glucose are kind of like, think about them like grains of sand or shards of glass circulating, very tiny, of course, but you get enough of them, and over time they can wear down areas of the body, specifically in the microvasculature and those tiny blood vessels, which is why you have diabetic patients who end up with neuropathy. They end up getting their the kind of pins and needles sensations in their hands and feet, and that's just kind of the tip of the iceberg. The worst cases are in the end organs, so heart, kidneys, and brain, not to mention the eyes as well. Brain and heart being most significant for stroke and acute coronary syndrome type complications. Renal disease can be managed, but is ultimately costly and could end up putting somebody in dialysis too. So there's a number of things that diabetes can diabetes can be a disease that starts pretty benign, but it ends up being a long-term killer. And if you couple that with high blood pressure, you couple it with high cholesterol too, you can easily see where some of these compound, and you end up with a pretty grim scenario for a patient. Okay, so I do want to talk about type 1 first, just to talk about insulin and get ourselves familiar with insulins. And then we'll go into type 2 and talk more about the oral therapies and also how insulin fits into type 2 as well. All right, so diabetes in general is probably one of the most common chronic diseases affecting people in the world. So if you practice in any area of medicine, you're going to see it. As far as diabetes type 1 goes, it's the most common chronic diseases affecting children. So if you work in pediatrics, you're probably going to get exposed to this at some point. It is an autoimmune disease, so it's one of the big differences between type 1 and type 2. So insulin-producing beta cells of the pancreas are being destroyed by the body. And that does take some time to do, and I'll talk about onset here in a second, some of the statistical stuff just for fun. But there are a lot of different components that have thought to be contributing to genetic and environmental, and no one's really exactly sure what causes it. Whether it's something that happens in the perinatal process or it could be a viral exposure at some point. We don't really know. Your body does fortunately have a large amount of beta cells to start with, so it does take this disease some time to actually destroy enough beta cells to really see an impact. So that's where we see that delayed onset, where people are born with this, but they don't see the symptoms until later in life. And the other thing about type 1 diabetes is you'll get, as we talk about therapy, this is considered insulin-dependent diabetes. So if you ever hear that term used, that's exactly what we're talking about here. All right, looking at some statistical stuff. This isn't anything I'm going to test you on, the epidemiology. I just think it's kind of interesting for type 1 diabetes specifically. So if we look at rates in children ages 0 to 14 years, this is kind of old information, but we see a lot higher rates in countries that maybe have Northern European descent. If you look at like England, of course, Australia being British colony at one point, Scandinavia, Canada, and then the United States sort of being a melting pot, but also having a pretty strong European heritage, at least for a large portion of the population anyway. Whereas if you compare that to like Southeast Asia, Central America, you see a lot lower incidence, which is very interesting. I think I don't really have anything to comment on this. I just think it's an interesting trend you see geographically. So basically what people have postulated is that further from the equator you have a higher incidence. However, they don't really find that in the US. So for example, people who live in Florida don't have a higher, or people who live in Minnesota, I should say, don't have a higher incidence of type 1 than people who live in Florida. But that could contribute to just having maybe a more diverse population throughout our country. We have a lot of different cultures coming together in the United States, whereas some other countries might have maybe smaller groups of populations intermixing with more of a standard ethnic group that makes up the majority of the country. As far as age and gender, there's kind of two peak onsets you see, although you can really have it occur anywhere between 0 and 14 years. Really, you could have a bit earlier, a bit later. But usually you're going to see an onset at 4 to 6 years, and then another onset peak between 10 to 14 years. About 45% of kids will present before age 10. So it's about a 50-50 mix of who's going to present in that earlier group, who's going to present in the older group, maybe with a little bit more in that older group. There is no gender difference. So we talked about gender in some of the other autoimmune diseases, and females in general have a higher incidence of autoimmune disease slightly than males if you look at all the autoimmune diseases. However, in this case, it's pretty similar to female-male ratio. Some populations actually have found male prevalence being slightly higher. And as far as trends go, the incidence is rising. So question is there why is incidence rising? And it's always something good to ask yourself when you're looking at epidemiological data. Are we studying this more in places in the world that previously maybe it went unstudied, undocumented perhaps? But I think the overall trend is looking at a rising incidence, and we don't really know what's necessarily causing it or not. As far as genetics go, I just put this on here for fun. Again, all this stuff is just for fun. None of it's testable. But looking at kind of the differences for genetics, if you have no family history, you have quite a low risk of getting type 1 diabetes, and then it goes up substantially if you have different parents affected. All right, so diabetes symptoms are pretty much the same across the board. Doesn't matter if you have type 1 or type 2. The symptoms of hyperglycemia are going to be very similar. So polyuria, so excessive production of urine. Usually people will see this when their blood glucose gets above 180. And if you haven't talked about blood glucose lab values, the normal blood glucose is anywhere from 70 to 120, 150 maybe on the high end. So once you get above that, like 180, 200, you might see some increase in urine production. Your body just wants to excrete this, so that's a mechanism to compensate to get rid of the extra glucose. There's more solute in it, and it tries to filter it out through the kidneys. Now, just remember back to our slide on what can cause long-term complications with diabetes, and this is a big part of this. So increased urination, increased filtration of glucose can cause that damage to that kidney microvasculature, which is why patients with diabetes are so at risk for kidney disease. Polydipsia is excessive thirst. Very similar concept here. Your body is trying to wash out the glucose, so it wants you to drink more liquid. And then weight loss. Hypovolemia, increased catabolism. You have impaired glucose utilization, and fat and muscle breakdown. Now, this symptom of weight loss is generally more associated with your type 1 patients because of the way that their the disease works. However, at the onset of type 2, you could also see maybe some slight weight loss too because of some similar nausea, anorexia type symptoms that you might see with high blood glucose. Okay, so let's get to insulin therapy and talk about this a little bit. So again, required for any patient with type 1 diabetes, and we'll talk about type 2 in a little bit. Therapy is going to start with diagnosis of disease. So as soon as somebody's diagnosed, it's not like you try something else or wait and see. You start them on an insulin regimen as soon as possible. And your goal is really just to prevent long-term complications. With type 1 diabetes, because these patients usually are presenting as children, they don't really have a lot of other issues going on as far as medical conditions. So it's pretty easy to manage them and to keep them from getting long-term complications if you control them properly with an insulin regimen. You can replace insulin fairly similar to how the body would do it. We can't quite do it perfectly, but there's a lot of products out there. There's a lot of options for patients. So we're going to talk through a few different of the common ones that people use. Before you treat, there's a couple different things I want to talk about because I'll use these terminology a little bit today. So conventional treatment was basically when insulin was developed, and early on in studying this, they didn't really have as complicated or as I should say as advanced of insulin formulations as we have now. So in the case of conventional, they were treating people with single or twice daily injections. This is really not effective for type 1 diabetes at all in any case, and I'll talk about why sometimes they use twice daily injections. Single injection therapy for a type 1 diabetic is going to be very ineffective. It actually would be probably put them into a ketoacidotic state of some kind. And it's just because your body isn't designed just to have one burst of insulin throughout the day. Your body releases insulin when it senses that you're consuming sugar, and it can sense that, and that's what the pancreas is doing. So if somebody doesn't have a pancreas, we need to mimic that process as best as possible by A, providing patients with mealtime insulin, and B, providing people with some standard base layer insulin. So, and that's really not what a conventional strategy is going to do. So that's where the intensive strategy comes into play. And again, it's mimicking that physiologic insulin. The outcomes data are better. Drawbacks, however, do have some drawbacks. You do have to inject more. You are at risk for hypoglycemia. Anytime you inject insulin, you're at risk for hypoglycemia. It's just it's a very high risk medication. We can do it very appropriately and monitor. That's why we check blood sugars regularly and frequently on these patients. But doesn't mean it's not a risk. And hypoglycemia can be quite nasty if it catches up with somebody and they don't get medical treatment quickly. So in that case, we do have to be very careful. Weight gain is more likely with insulin, and so people do see weight gain. That's with type 1 and type 2 diabetics, actually. And you'd think maybe they'd lose some weight, but actually they're utilizing some of the glucose so they can more efficiently, so they can actually put on some more fat and so on and so forth. And then cost. Increased cost is a little bit debatable if we want to compare it to some of the other strategies. However, if you compare it to like a conventional single or twice daily injection, yes, doing intensive therapy with meals and baseline is going to be more expensive. So we're going to talk about these and go through the types of insulin in more detail. So this will make more sense as we get further along here. All right, so insulin is, of course, an injectable. Insulin is a peptide hormone. It is something that the body cannot ingest orally, so you can't put it through the GI tract. Your body, basically, that's the reason why we have to inject any type of protein or biologic agent that's made up of amino acids, because your body is designed to break down peptides and proteins and to metabolize them into their individual amino acids. So we have to inject insulin. And for a long time, insulin was used out of vials. So people would buy like a vial of Novolog and then inject with individual syringes. Probably, I don't know, at least 10 years ago, pens became pretty popular, maybe even longer than that. And a pen is a preloaded syringe, basically, is all it is. But it's got this fancy counter on it. And so you can see here that there's this twist thing where you can see the person's holding it here. And sorry, this update thing's annoying me. Okay. So there's this counter on here you can see. And you can see it starts at 0. What that twist knob allows the patient to do is to dial it into the specific number of units they'd like to inject. And then you can see the volume of the insulin in the cartridge. So you can tell when your insulin's getting low, and then you can inject that way. These do have a max on them, so usually it's 60 or 80 units, depending on the product. So if you have somebody on a really high insulin dose, which is possible to be like over 100 units in a single injection, for sure, I've definitely seen it multiple times, you'd have to actually do 2 separate injections. You'd have to twist it all the way out to 60, do an injection, and then you'd have to do it out to 40, like let's say you're doing 100 total units, and then do another injection. These are designed to work with pen needles. So these are individual needles that are single use, and the end is kind of a lure lock tip, and so it twists onto this, and they would inject this fine needle subcutaneously. Insulin is always injected subcutaneously. The only difference would be using regular insulin IV in like a emergency situation. We can give that intravenously, but generally we're just doing sub-Q shots here. So the options are here, and I'm going to go through them in a little bit more detail. Basically, you have 3 categories. You have basal, which is long-acting, intermediate acting, which are sort of a hybrid between your basal and long-acting. They kind of have a bit of a different kinetic profile, and I'll show you how that works in a second. And then you have your rapid-acting or your mealtime insulin. It's going to work very quickly. For most insulins, pretty much every insulin on the market is going to be 100 units per milliliter as a concentration. However, a lot of companies are coming out with more concentrated products now, and the reason is because you have those patients who are on really high doses, and if you give a lot of volume subcutaneously, it just gets difficult for the body to absorb it effectively. So if you can concentrate that down and give a lower amount of volume, they have shown that sometimes that improves the absorption of the actual insulin product. So sometimes we're seeing more products that are 200 units per mil, 300 units per mil, and even there's an old product actually that's a regular insulin called U500. It's 500 units per mil. And we'll talk about the challenges with that here in a second, and what to think about that. Just to show you how like a non-diabetic endogenous patient would use insulin. So your pancreas is going to release insulin. It's 100% bioavailable immediately, and it works very quickly. Whereas the insulins we've developed to be injected don't quite work that quickly. Think about sub-Q injection. You have to inject it subcutaneously. It has to absorb from that subcutaneous tissue into the circulation to be used. So there's always going to be some lag time. But if you look at the different kinetics with the different agents, you'll see a lot of variety in what we can inject. So for example, regular insulin has kind of the slower peak. It doesn't have quite as high of a peak, slower onset, and not quite as much area under the curve. You can see something like long-acting would just have a very slow ramp up, and then it stays pretty steady over the course of the day. And that's designed just to provide you a low basal level of insulin. You have a number of in-between options, intermediate NPH, which has a slower onset and also kind of a slower duration. And then you have some combinations. So there's mixed products that contain both long or intermediate acting plus a rapid acting. So you get a little bit of a burst of rapid action from that initial injection when you get the effect from that fast acting analog, and then you end up with the longer acting kicking in later. So this slide compares a number of the products, and there's some that aren't on here. There's a couple newer ones that I don't have, some newer mixed products and a new long-acting product that's not on here, but this does a pretty good job comparing things if you want to look at durations, and I've spelled it out a little bit on the next slides too. It also shows you some costs associated with insulin. Basically, insulin's not cheap. Most insurances pay for it because it's an essential medication, so it's usually not a huge deal. However, if you do have a patient with limited resources or not insured, and they're paying cash, it does get challenging. So that's where you have like medications like NPH that are $52 for a vial, or regular insulin that's $53 for a vial. Save patients a lot of money over some of these other more expensive pen formulations. Now, pen products contain or represent our more effective regimens. Regular and NPH-based regimens just aren't as effective generally. However, you will see patients using them from time to time. Mostly it's due to cost issues when you see that. All right, so let's talk about basal insulin a little bit more. You have 3 basal products on the market. Glargine is the most common one. It's been around for quite a while, and it was the first one and probably the one that's been on the market for a really long time that's just had a very consistent level of insulin that it supplies. It doesn't really have a peak that it hits or a Cmax or anything. It just kind of provides this really steady basal rate, and it lasts for about 24 hours. There's 3 different products. There's Lantus, Toujeo, And there's a new one called Basaglar that I don't actually have on here. I can write it in here. Basaglar, I think that's what it's called. Basaglar is a U100 product. And remember this, what I'm saying here when I say U100 is 100 units per mil. So Toujeo is a product that's basically just a concentrated version. So it's 300 units per mil. So again, for those people who are in really high doses of basal insulin, they're looking at a product that's a little bit more convenient for them to inject. So if you buy a Toujeo syringe, you're getting essentially, because each syringe has 3 mils of liquid in it, so you're getting 900 units versus 300 units. So you can have a patient, because if you have a patient who's going through a couple hundred units a day of insulin, they're churning through pens really quickly. So these concentrated products are actually really helpful in those situations. However, I wouldn't prescribe them for somebody unless you really got to that point where you need that concentrated product. Don't just give them to somebody right off the bat. It's not really appropriate at that point. So anyway, you have Lantus dosing. Lantus has been the product that's probably been on the market for the longest, and it's this gray pen, this Lantus Solastar. And you'll see people using it mostly once daily because it has that 24-hour duration. Every once in a while you see BID Lantus dosing, so don't be weirded out if you see that. It is appropriate. It does work that way. And I think even though people don't think Lantus has really all that much of a peak effect, and if you're giving it once a day, it should have a pretty sustained, consistent blood concentration it's providing of insulin. What you can get is people who just, for whatever reason, process it faster. So in different reports, they've shown some people will get only about a 10-hour, 11, 12-hour duration out of it, so about half of what its predicted duration is. But some patients actually might get over 24 hours, maybe up to 30 hours. So there's some variability there. And that creates an issue, especially if you have the patient on the lower end, then you end up dosing it twice a day. You aren't really getting that good basal effect like you thought you were. It can be kind of a problem. Degludec is a new product, and I think I put the brand name on the other slide. Did I put it back here? Yeah, here it is. Tresiba. So Tresiba is, or Degludec is, comes as a U100 and U200. It's brand new, like it just hit the market like within last year. It's got a 25-hour half-life. So when we say Lantus has a 24-hour duration, don't think duration and half-life are the same, because remember, you've lost half of your effect after 25 hours. So you're still going to get a fair amount of effect after that. Half-life has passed. So remember, we're looking at 3 to 5 half-lives for full elimination of the drug. So you could be like 2 days before you really are out on your Degludec. It is approved for both type 1 and type 2, so it's looked at trials on both of those. And they did show one of the advantages, it's basically not inferior to glargine. However, its advantages are that it has lower nocturnal hypoglycemia. And again, sometimes with glargine, because people don't get that full 24-hour duration, they do end up getting some nighttime hypoglycemia with it. Or they might get more of a peak effect because they're taking at bedtime than they expect with it, whereas Degludec seems to have a more steady state approach. So, glargine works for the majority of patients, but Degludec is a nice option. And I think also you have maybe a more flexible dosing. So if you miss a dose of Degludec, you still have a lot of it on board. If you miss a dose of Lantus, you do need to replace that very soon. Otherwise, you're going to lose it. So Degludec does last longer. Then there's Detamir. Detamir is the shortest acting of the basal insulins. It's usually dosed twice daily, always. It's rarely ever dosed once daily. Its duration is about 9 to 23 hours, 23 hours on the max end there. So think of it as a BID medication primarily. Mealtime insulins are pretty straightforward. You have 3, glulisine, aspart, and lispro. They're all basically the same, and really you're going to pick the one the insurance covers. They all come in pens. Humalog does come in as a U200, so that is an advantage to that specific brand of the product. I imagine we're going to see lots of other different concentrations coming out for the different Novalogs and other products too, and Apidra products. But for now, you do have that advantage of having a more concentrated Humalog formulation if you need it. But basically, insurance is going to pay for one or the other. We use Novolog at our hospital because of it's just more efficient, cheaper for us to buy that than Humalog. But they are basically all the same. They all have very similar kinetics. Your onset's looking at about very, very quick. So you're looking at less than half an hour for an onset. Peak effect 1 to 3 hours. Duration about 3 to 5 hours. So if you're ever wondering, if I give somebody a shot of insulin in an urgent care ER, how long is it going to take for their sugar to come down? These are good numbers to know. Other things, we have NPH. NPH is has a similar kinetic profile to Levemir, not quite as Levemir doesn't have as sustained, insulin detamir or Levemir doesn't have as sustained peaks, but it's going to be a little bit different as far as giving you more of a bolus in a higher Cmax than Levemir would. However, it is still similarly dosed twice daily. You can also do regular insulin 3 to 4 times a day, and again, regular comes as a U100 like all insulins. It also comes as this U500. I'll take a second just to talk about concentrations. U500 historically has been considered one of the higher risk medications, and we get really scared every time we see somebody come into the hospital with it, because if you mess up U500, you can kill somebody fairly easily, because insulin overdoses, it's not hard to do. If you have somebody who's a really resistant diabetic and you accidentally overdose them on it, they might be okay. But if you accidentally gave that to somebody who's naive or just has mildly elevated blood sugar, it could be a real problem. So there's lots of case reports and safety issues around U500. So 5 times concentrated insulin. One of the big issues around U500 is that people will dose it weird. So I'll just do a little example here. So maybe somebody's insulin dose says 25 units TID regular insulin. Well, that makes sense, right? You're doing 25 units TID of regular insulin. Now, they might say that same dose, but say U500 insulin. Okay, so what does that mean if you see that? Does that mean they're using 25 units each time? Well, in actuality, what people mean by that is, and because regular insulin doesn't come in as a pen, it comes actually as a vial, that they're drawing up to the 25 unit marker on an insulin syringe on a standard syringe. So these patients are using a U100 syringe and drawing to that 25 unit mark. So in actuality, they're getting 5 times that dose. So they'd be getting 125 units regularly because it's 5 times that. I hope I explained that well. It's kind of complicated, but the first time you see it, well, basically all I'll say is that if you ever have a patient that you're reviewing their chart and you see regular insulin, it's always a thing to double check and make sure that somebody entered it correctly. We're very careful when we take patients in the hospital to make sure that everything's in total units. We don't want to mark it as, well, they're taking 10 units, but they're drawing it up on a regular insulin pen, or a regular insulin syringe, excuse me. So they're actually taking 50 because it's 5 times that. Well, that's just too complicated. Just tell them I'm taking 50 units total 3 times a day, and I'm using the U500 product. And that's clear. We can figure that out. But it does get complicated, and because patient products, as far as syringe availability, are usually in U100 gradients, so that they aren't asking patients to drop in terms of milliliter. They're asking them, the insulin syringes out there are designed to drop per unit. So if you're taking 20 units, you drop to the 20 unit gradient, which is 0.2 mils, but it's easier for patients to read that unit mark than that mil mark. And in this case, it does get quite complicated and kind of problematic in certain patients. Whoops. Regular insulin, again, relatively cheap, so you do see patients on this regimen occasionally. Okay, mixed combinations. There's a bunch of combinations out there that I put down here. And again, basically, they're just short-acting plus long-acting or intermediate-acting products. Initial regimens. So your total daily insulin dose is going to be usually weight-based. And now this is just a recommendation. So this isn't an absolute, so don't think that there aren't other ways to do it, but this is kind of a standard way you'd look at it. So initially you're looking at 0.2 to 0.4 unit per kilo per day total daily insulin dose. If you have a teenager you're dosing who's maybe an early onset patient, they might need a little bit more eventually. However, you're usually still going to start with that same initial dose. You just might ramp them up higher. And then you can adjust doses daily, so you don't have to wait like weeks to see effect, because you're going to see that insulin work very quickly. And assuming they're measuring their blood sugar regularly, they should be able to report that to you. And so basically, once you get your weight dosing down, you're going to divide it in half. Half of it's going to be given as basal. The other half is going to be given as your rapid acting or mealtime, and you're going to kind of split it up there. So here's an example. of mealtime. Basal is pretty straightforward. You just do half. You do your total dose. If it's Lantus or Glargine, you're going to give all of it at once for the most part. If it's Levemir, you're going to split that in half and do it BID. When it comes to your mealtime products, it's a little bit more complicated. There's a number of ways you can do it. Sometimes I'll see people just on a fixed dose where they take 10 units per meal every meal and at bedtime. Well, it's not really flexible. So what if you eat a really low carb meal in the morning and you eat a really high carb meal at lunch? That's going to be the same amount of insulin for not the same amount of carbohydrates. So usually what people do is they meet with a dietitian. They learn about carb counting. That's a very core concept of both type 1 and type 2 diabetes, to be able to carb count. So I'd recommend strongly sending all your diabetic patients to a dietitian if they haven't met with one in the past. You can do a number of combinations too, and sliding scales are really popular. So a lot of times, probably one of the best ways to manage insulin is to do a carb count plus a sliding scale. So basically, if somebody's going in for their lunchtime meal and they're saying, well, okay, this is a high carbohydrate meal, this is whatever, 5 carbohydrate units or whatever it ends up being. I'm not a carb counting expert, but let's just say that's what it is. So then they have a scale that says, okay, depending on how many carb units, you would inject this much. So maybe it's 5 units of insulin per carb unit. So let's say they're going to do 5 carb unit meal. That means they're going to be injecting 25 units right off the bat. Now, on top of that, they have a sliding scale. Maybe they check their blood sugar and it's 203. So that means they would add an additional 2 units of insulin on top of that. And that's going to compensate for the fact that their blood sugar is already a little bit elevated. That's the point of the sliding scale. You might have a fixed dose plus a sliding scale. Maybe somebody's meals are pretty consistent. So like if they're in a nursing home and it's relatively the same, maybe it's more controlled that way. They can control what types of carbohydrates and the quantity of carbohydrates patients are consuming. In that case, maybe a fixed is fine, but I would always have a sliding scale on top. That just compensates, that prevents the blood sugar from getting high and out of control, gives you that little extra boost you need. And this is just an example of kind of your standard sliding scale where it's like a 0 to 5 scale. Of course, you could adjust that as much as you want. I've seen them, go up to 20 units for the high end. So really you can inject quite a bit at once. And sometimes you will see people who are doing tons of insulin a day, like hundreds of units a day. So don't be too surprised if you see that in certain cases. All right, blood glucose monitoring is a critical part of diabetes management. And there's a lot of monitoring systems available. I just want to touch base on this, even though it's kind of outside my realm of expertise. However, most of the time you're looking at a 4 to 7 times a day testing. People are usually doing it with meals at bedtime. If they're exercising and they're type 1, it's probably important to test before and after, just to make sure that they aren't getting hypoglycemic during those processes of intense exercise. A single blood sugar is only really a snapshot, so just remember that if somebody has one errant reading, it's likely not a big deal. You want to look at trends. Most monitors have a ability to either check a trend or pull trends. A lot of them now interface with smartphones, and so people can log, or people can manually log them to in a smartphone app as well. So there's lots of technology. I really recommend people use that to their advantage if they have those types of resources, because it's helpful, especially helpful with teens these days, being able to be so connected everywhere. I'm sounding really old saying this, but basically you guys get the point, right? Everybody has a smartphone, everybody uses it. It's really important to take advantage of that, and so if you can keep track of all that in there, it's just a no-brainer. So with that in mind, there's a lot of different products on the market. Sometimes insurances will dictate which one. They're all pretty much the same. Some of them have varying different types of levels of convenience. Like this is just kind of a look of a standard generic one. This is a one-touch product. It's kind of a smaller oval shape. It's maybe a little bit easier to carry. It also comes in different colors, so people can match them to whatever their favorite color is or something like that. But there's tons of different ones out on the market, but they all pretty much do the same thing. So just make sure a patient has access to these. Insurances pay for them. The meters are usually free, and then people pay for the strips, because the strips are going to be what keep people coming back, and that's what the companies make money off of. Hemoglobin A1C we'll talk about with type 2 diabetes, because it's not really relevant with type 1. It doesn't matter. And then, of course, there's continuous infusion insulin pump. So this is really probably the standard of care when it comes to effectively managing somebody's type 1 diabetes. The problem is that a pump, while you think about it as, well, it's a pump and it continuously infuses, it does everything for you, it's automatic. You can give it to a non-compliant patient. Well, that's absolutely incorrect if you're thinking that, so hopefully you aren't. Pumps require a highly compliant patient, somebody who's done very well with an early insulin regimen and shows that they can handle a pump. A pump needs, first of all, you have to monitor your blood glucose regularly. You have to know signs and symptoms of hypoglycemia. You have to be able to react if the thing malfunctions or runs out of insulin. You have to be able to refill it appropriately. And you just have to know how to use it. So there's a number of things that could create barriers to use, but the majority of patients, you're going to see a lot of pump use, and that's a good thing because pumps do help people. They are better at managing this disease than standard injections. So what does a pump do? Basically, it's just a lot of rapid-acting insulin. You're using one type of insulin. Usually it's going to be Lispro or Aspart. You could see regular pumps too, but that's rare. If you think about the way if you look back to that kinetic profile slide with the graph with the different onsets of action, you think about endogenous insulin, works very quickly and disappears very quickly. So pumps are designed to do the same thing. So you can program a pump to do a number of things. You can program it to do a basal rate. It's always going to have some kind of a basal rate. And then it's usually going to have some sort of a bolus. So you can give yourself a bolus of insulin for a meal. You can adjust your bolus if you're having more. There's even a lot of technology that's growing now. It's not really there yet, but to make the pump essentially function as an exterior artificial pancreas, basically. So it's going to, like, for example, here's a drawing of how this might work. So you have the pump that's infusing subcutaneously, just like all pumps would do. And then you have a sensor that has a wireless transmitter. Bluetooth connects to the pump, and it measures your blood glucose. So this is measuring blood glucose, and it's telling the pump, hey, the sugar's high, increase that rate a little bit. And that's really what the future is going to bring with this. And I think we're already there. I think some of the devices are doing this. I'm not totally up to date on my pumps, but basically, the more advanced our technology gets, the more these things are basically like exterior pancreases. And we're looking at artificial implantable pancreases too, so you'll hear about that on the news from time to time. All things that are going to hopefully help this disease be much more manageable in the future. Hypoglycemia. So for type 1 diabetics, this is the highest risk side effect because insulin doesn't do a whole lot other than manage your disease, but it's going to possibly work over in some cases. And in that situation, you want to make sure your patient's ready to manage that appropriately, because hypoglycemia can be deadly. Hyperglycemia can be deadly too, but you have to get really high blood sugars. Your body can handle a ton of extra sugar. It can't handle being really low very well. So the side effects I listed on this chart here are pretty straightforward: sweating, dizziness, shaky, hungry, headache, irritable. If you remember back to when we talked about beta blockers, people will get tachycardic when their blood sugar is low. So if they're on a beta blocker for some sort of a cardiac disease, you have to let them know that that's not a side effect they can expect, so they aren't going to feel that fast heartbeat. Whereas that's a really fairly remarkable thing type 1 diabetics will feel when they're hypoglycemic, that they can feel their heart racing. They're like, I'm getting low blood sugar at this point. So sweating, dizziness, some of those other side effects would be something to counsel somebody on if they're on one of those beta blocker medications. The treatment, fortunately, is quite easy. You just give sugar. So consuming any simple sugar as soon as possible. There's specific products on the market that are dextrose products that are designed to deliver sugar very rapidly. There's one that's like a glucose dextrose gel that we use in the hospital called Glutos. There are some tablets too people can buy. You can use whatever you have at hand. If you have fruit juice, pop, if you have candy, anything's better than nothing. So just remember that the more complicated of a product you consume, so if you eat like a Snickers bar, it's got like nuts and milk, fat, and all types of stuff in it that's going to slow down the digestion of the sugar. It's not as pure where if you ate like a whole bunch of Skittles, apparently that's pretty much just straight sugar. So think about it that way. So I mean, again, anything's better than nothing. Peanut butter and jelly sandwich and a glass of orange juice, it's great. The orange juice will absorb really quick. The peanut butter and jelly kind of gives you a little bit more of a sustained absorption. It's something they do at the hospital for people who are a little bit low and they just want to manage it with diet that way. Severe hypoglycemia, you end up coma, seizures, death. If somebody comes in with severe hypoglycemia, we give them IV dextrose quickly. It's a very fast way to get that sugar back up, and you can correct the problem essentially instantly. Ambulances have access to this too. It's a very easy fix. Glucagon is a peptide hormone produced by pancreatic alpha cells. So your body releases this when your blood sugar is low, and it triggers enzymatic activity that results in the release of glucose from various glycogen stores. There's a synthetic version that's available on the market. It comes in this kit that's like red and has a vial and a syringe in it. So you pull up the vial, and then you would inject it IM or sub-Q. IV dextrose is a faster and better option. However, to make IV dextrose effective, you have to give a fairly decent volume of it. Like an emergency dextrose syringe is about 50 mils of liquid. It's really not convenient for somebody to carry that around. And specifically, you can't give that volume IM or sub-Q. So this is designed as a product that people could actually have, on their person, be able to inject easily if they need to. Can buy them some time until like EMS is able to come. So from that standpoint, glucagon has a good role in therapy, but it's mostly for the outpatient world. Ketoacidosis and DKA and HHS. I'm not going to talk about these a ton. We'll talk about these a little bit more with emergency medicine because they come into play during that lecture. I'll review it there. It's here for your review if you're interested in it. Basically, this happens if your blood glucose gets really high. So if you aren't taking any insulin, eventually your blood glucose is going to go sky high. You get presence of ketone bodies in the urine. Treatment, you want to dilute it, you want to give insulin, and usually we start people on regular insulin. We give high doses, we give it intravenously, and we give it as a continuous infusion that we can titrate. We have this special monitoring protocol within the Atlanta hospitals that allows nurses to plug in glucose values, and then they can adjust the rate based on what the calculator tells them to do. It's a pretty well validated therapy that has a really low rate of hypoglycemia. So it sounds really aggressive, and it is, but we monitor it very aggressively too. So we try and prevent those hypoglycemic episodes from occurring. Potassium, also very important. If you're giving anybody large amounts of insulin, remember that that's our primary treatment for getting potassium down in hyperkalemic cases. So if somebody's normal potassium levels, or if they have normal potassium levels, you'll see that drop potentially. So that's something just to keep in the back of your head. HHS is very similar. Treatment's very similar. DKA is more associated, I think, with type 1 diabetics who aren't compliant or controlled or haven't taken insulin in a while, or maybe a new onset case. HHS I think of as more of a type 2 diabetes out of control type situation, but the treatment's very similar. All right, type 2 diabetes. Here we go. My funny joke for the day. You think about Michael Phelps does not have diabetes, I don't think. Pretty sure he doesn't, and I can't confirm that this guy in the other picture does either. However, you think about like type 1, type 2. Type 1 patients tend to be lean and actually kind of muscular, and then type 2 patients tend to be overweight, and that's just associated with what might have gotten them to the point where they have diabetes, just having too much sugar, too much fat in their diet over a long period of time. So controlling factors, you have different things that contribute. Of course, high glucose intake is a big one, but other things that are going to compound the factor. We talked about high blood pressure. Smoking, of course, can cause issues too. Sedentary lifestyle, being overweight, high fat cholesterol foods. Essentially, you end up with so much glucose in your body that you get resistance, and that becomes the primary target for what we're trying to correct here. Sugar. I don't know why I have this slide on here. Everybody knows that people probably eat too much sugar. The point of this is just to talk about sugar comes from a lot of different sources. So I think people think, well, if I cut out all high fructose corn syrup from my diet, I'm going to be okay. But it's not necessarily the case. There's tons of different types of sugar. It's all really the same. If you drink a whole bunch of fruit juice, that's a lot of sugar. If you eat fruit, on the other hand, you're getting a satiety sensation as well because that fiber and the bulk of the fruit is taking up space in your stomach. So kind of just some things to think about. I'm, of course, not a dietitian, so I'm not going to get into this too much. However, sugar is a big factor in this, so making sure people are, again, making sure you're enforcing that diet aspect with your patients is critical for diabetes. And that not only goes with the diet side, but also exercise too, can help people to manage this at least partially on their own, maybe with the assistance of some medication. So again, big plug for dietitians. They do a great job, and you should always refer a diabetic patient to a dietitian. This is just a chart that talks about body weight and increased risk of diabetes, in case you're curious. So diabetes as a total disease, type 1 and type 2 together, 8% of the US population is affected, which is quite a few people. So of course, this is going to be something you're going to see very regularly in your practice, especially if you work primary care. This is kind of going to be your bread and butter, along with blood pressure and cholesterol management. About 25 to 40% are estimated to remain undiagnosed, and all diabetics, if you take them in a pool, 90% of them are type 2. So when it comes to the lion's share of what we're talking about is who you're going to see coming into your practices, you're going to see type 2 diabetic patients much more commonly. Your normal labs, fasting blood glucose should be below 100, and your A1C, hemoglobin A1C, which we'll talk about on the next slide, less than 6.5%. Screening criteria for type 2 diabetes: A1C greater than 6.5, blood glucose fasting greater than 126, 2-hour blood glucose greater than 200 with an oral glucose tolerance test. Oral glucose tolerance test is just drinking a fairly concentrated amount of sugar and seeing how your body processes it, and then taking a blood glucose later. If you've ever had a pregnant wife that's done this, or been pregnant yourself and done this, you'll know it's the exact same process. They use this as a screening tool for gestational diabetes as well. But the other main tool, while I talked about blood glucose really being like a trend, so we're looking at trends as far as instead of getting really excited about a single monitoring event, the bigger way to track trends is to use A1C percentages. So hemoglobin, or glucose molecules, bind to hemoglobin. So what happens is your hemoglobin will always have some sort of glucose bound to it. It's just the way it is. And so if it's less than 6.5% of your hemoglobin is glycated, I think is the correct term, you end up with a normal reading. If you're above that, you probably have too much blood sugar and you're overly glycated as far as your hemoglobin goes. So that's where this A1C comes into play. And A1C is basically like a several month snapshot. So when you take somebody's A1C, it's like, okay, I have 3 months worth of data of how your blood sugar's been doing, because that's about the life cycle of hemoglobin. And so if you're looking at that versus looking at their blood sugar trends, you should look at both. But A1C is much more important for diagnostics. It's much more important for targeting things. And it's going to be what we're talking about when we're talking about how drugs impact this disease, how effectively they can lower people's A1C. Okay, so this is a table I pulled. I actually overhauled this part of the lecture quite a bit this year. I kind of was going a little bit old school with my diabetes lecture, and I'll talk about some of the old school theory too, because I think it's still pretty popular. However, I did this new CE that I thought really kind of drilled into the new guidelines really well, and I'll talk about all this stuff in more detail. However, this is a nice slide that I'm not going to test you on, but it does show you A1C goals. So I think this is important reference point. It shows you basically what people are looking at as far as what clinicians would look at as far as different types of criteria people might meet to choose a goal. So for example, if you're looking at just a healthy patient who's got a relatively new onset with no real complications, both the ADA guidelines and the AACE guidelines, ADA being the American Diabetes Association and AACE being the American Association of Clinical Endocrinologists, are the two major groups who put out guidelines, and they're kind of similar, but actually there's some really big differences between the two schools of thought. It's kind of interesting. But their goals are fairly the same. So basically they're looking at less than 6.5 or targeting a 6 to 6.5% goal in these patients. Pregnant patients, you can see that increases a little bit for ADA, but AACE actually targets a much more aggressive goal in pregnant patients, and are generally a little bit more aggressive than the ADA goals in general. One thing I'll point out too is with older adults, it's usually okay to slide up that A1C. It's very hard to get an older diabetic patient down to below like 6 or 7. In this case, you can really treat your patient a little bit better and not aggressively target them. What happens is if you target people too aggressively, you end up adding all these therapies. You put people at risk for hypoglycemia, excuse me, and other risks as well. It ends up being problematic. So in this case, both guidelines do support a bit more of a generous goal for your older patients. And then, of course, there's some gradients in between for more complex diseases and so on and so forth. So we talked about weight reduction, diet, exercise. Very few people clinically can actually control diabetes with non-pharmacologic options alone. Once people get to the point where their A1C is heavily elevated, it's very difficult for them to do it with just diet and exercise. There have been some trials looking at this. So there's one big trial in the UK called the UK PDS that looked at low-calorie, low-fat, high-complex carb diet, which you might think, well, I don't know, that doesn't sound like the best diet to me. Well, kind of irrelevant. The point is they looked at controlling people's dietary intake, and they did an exercise program as well as incorporated with it, and about 3% actually achieved their fasting blood glucose goals with this trial. And they found out that compliance with exercise programs is not lasting, which, do we really need a clinical study to show that? But the point is that, when you're talking about all these medications, and some of them are actually quite expensive, newer, there's a lot of new medications coming out for diabetes that continue to pour into the market. We spend a lot of money on managing this disease. Should we be doing all this, or should we just be focusing on the basics? And while I would totally say that the basics, diet and exercise being the basics, are essential for managing this disease, I think they're just a cornerstone. I think when you have somebody with an elevated A1C, you have to consider medication too. At the end of the day, could you get somebody off medication at some point? Sure. If you get them down to an A1C of 6, they're on metformin, and their exercise and diet is outstanding, maybe try getting off the metformin and see what happens. I'm totally on board with that, but I think we do have to take both things into consideration. Of course, I'm a pharmacist, so let's talk more about the medications. All right, metformin. So metformin is the cornerstone of both major guidelines. It's been the longest studied med. It's the most effective med, and everybody pretty much agrees that metformin is great for type 2 diabetes. So that's nice to know. Whereas with the other drugs, we get a lot of shades of gray on what's good and what's bad. So metformin is, again, first line. You should get about a 1.5% reduction in A1C initially taking metformin, which is really good. Metformin's mechanism is it works on a number of different ways, but overall it improves utilization of glucose within the body, which is important because it doesn't really have any effects whatsoever on your body's production of insulin. To talk about some of the theory on that in a second here. However, the other big point to think about with that is you have very little risk of hypoglycemia when taking metformin. In fact, you have almost no risk of getting hypoglycemic because it doesn't really have any effect on insulin. Your body really, to have a hypoglycemic episode, you really need to be manipulating or injecting insulin, and in this case, you just aren't doing that. First-line therapy, again, contraindications, here we go. Estimated GFR, aka creatinine clearance, we're looking at about 30 mils per minute being a contraindication. Now, this has changed back and forth a little bit. The new guidelines support this. Now, there is some standards on how to dose people in between like 60 mils per minute and 30 mils per minute, which would be basically your people who are kind of on the upper end of normal to like moderate kidney disease. And then once you get to severe kidney disease, you're basically done with metformin. They used to just have a straight serum creatinine cutoff. So it was basically your serum creatinine is 1.5, you're a man, you can't take metformin. Well, they've come back on that recommendation and say, this is dumb. We don't do any other drug dosing this way. Let's do GFR or creatinine clearance and look at it that way. There is a risk of something called lactic acidosis. So lactic acidosis is thought to happen when you accumulate metformin, and it's associated with sepsis, dehydration, and hypoxemia. However, we don't necessarily know what would cause it from metformin. There was another drug that was like fenformin or something a while ago, similar medication, not on the market, not available anymore, that had a kind of well, I wouldn't even say a strong incidence. It was a couple reports that ended up being, a minor incidence of this. But it is a serious thing if it happens because it can give kind of like a systemic inflammatory response type situation. So It is a serious side effect. And they think that it was due to renal elimination, poor renal elimination, accumulation of the drug. Now, with metformin itself, the evidence is really weak that it actually has anything to do with lactic acidosis, and most studies show that it doesn't. However, we still take it into consideration, and we dose adjust it, and we avoid it in our renal dysfunction patients for that reason. The bigger side effects that you're going to encounter with this medication are GI related. So diarrhea, nausea, and vomiting and flatulence are going to cause people to just not take the medication at all. 10 to 50%, up to 50% incidence in some studies. The product does come in a regular and extended release. So the extended release product is a little bit better causing this. However, if you get a patient with this, you're probably just going to move on to another class, unfortunately. But again, there's a lot of people that will tolerate metformin just fine, and you don't have to worry about that side effect. Next, sulfonylureas are a group of drugs that historically have kind of been our second line therapy. However, there's a lot of controversy around them currently. So what they do is they stimulate insulin release from the beta cells. They reduce glucose output from the liver, and peripheral insulin sensitivity is increased. So these drugs, contrast to metformin, work very aggressively on stimulating those beta cells to pump out more insulin. So hypoglycemia is a huge side effect. You have to take it with meals. If you're taking it and you have an inconsistent meal schedule, it's a bad idea to take a sulfonylurea because you're putting your patient at risk for hypoglycemia. It does reduce A1C by 1 to 2%, very good numbers. The effectiveness does tend to decrease over time, so you get some diminishing returns as you are on the medication chronically. And a lot of that theory is because of the way that the medication works by stimulating those beta cells. There's some school of thought that says that that's a bad way to treat this disease, because you want to make sure your patient's beta cells, the ones they have that are still kicking on insulin and working and aren't shutting down because of the severity of their disease, are staying functional. And there's some again, school of thought that says that sulfonylureas don't do that. They're going to cause beta cell failure over time, and you're going to end up with people who have type 2 diabetes and almost go into a type 1 type picture. They're going to be insulin dependent because no drugs are really going to work for them. So sulfonylureas, while they're still part of a lot of guidelines and have historically been super popular, have really fallen out of favor in the recent literature and recent schools of thought within the endocrinology community. However, they're still used all the time. I see tons of people coming in on them in the hospital. It's a very popular medication. So again, with any new change, you're going to have to take it with a bit of a grain of salt, because it's going to take a while to see that. But I do think that the theory behind it actually makes sense. I was always kind of skeptical on the theory that sulfonylureas shouldn't be used as kind of second line or almost first line in addition to metformin. However, I'm kind of coming around and buying into that now a little bit more than I used to. So I think the logic behind it actually makes pretty good sense. So I'll talk about the guidelines and show you their algorithms at the end after we talk about all the meds. So kind of wait until that, and then we can go through those together. 3 drugs: glipizide, glyburide, glimepiride. They have varying degrees of usefulness. Glipizide is probably the most common one. It's short acting, but it does come as an extended release. It doesn't require renal adjustment, which is really nice for a diabetic drug to have no renal adjustment needed. And again, your hypoglycemic risk is a big thing with this medication. You have, after exercise, missed meals, a high risk for hypoglycemia. So weight gain, hypoglycemia, and then that beta cell issue with causing more beta cell failure over time being the biggest problem with these medications specifically. All right, thiazolidinedione, that's a mouthful of a drug class, or TZDs. There's really one on the market only now. It's called pioglitazone, or Actos is the brand name. Bit of controversy behind this medication, and its cousin, rosiglitazone, or Avandia, was on the market for a while. It was actually removed due to perceived increased risk of myocardial infarction. However, this restriction was reversed by the FDA late 2013. I'm not sure if they put it back on the market or they figured, lost cause at this point. But it's interesting because that was these 2 drugs are one of the older classes of medications, and to have competition there was pretty big. So that decision probably lost that drug company, lots and lots of money. But anyway, that's neither here nor there. So we'll move on. Pioglitazone actually has before we get into the mechanism, has a risk for bladder cancer that they think it's associated with, and it's actually pulled off the market in France and Germany because of this. It's still on the market in the US. I don't think the clinical data is sufficient enough really to support pulling it off the market, but they did in some countries. Mechanism, it's a PPAR gamma agonist. So what that means is there's a gene, PPAR gamma, which is involved in glucose and lipid metabolism, which this drug activates and helps to upregulate, so you get better metabolism and use of your glucose and lipids. It doesn't improve target cell response to insulin, does not increase insulin secretion. So it's a drug with very low hypoglycemia risk, kind of like metformin. Lowers A1C variable. Basically, I put the lowering A1Cs on these slides. Basically, what you can think about is that metformin, 1 to 1.5%. Every other drug you add on, you're looking at maybe an average of 1% lowering, something like that. So with compounded therapy, you can get people from a 10 to a 7. Think about that with triple therapy, usually, on average. Now, that varies a lot what people are going to get, so your mileage may vary with different drugs. However, that's generally the rule of thumb. So back to this drug. Side effects, weight gain, fluid retention, and bone loss. Big deals for A, people with osteoporosis. You wouldn't want to use it in. B, fluid retention, heart failure exacerbation. So these medications are contraindicated for heart failure, strongly precautioned against people contraindicated with advanced heart failure, and for the most part not used in heart failure patients at all. DPP-4 inhibitors are listed there. They're the gliptan drugs. So what they are the mechanism. DPP-4 is dipeptidyl peptidase 4 enzyme, which inactivates incretin hormones. Incretin is responsible for regulating glucose homeostasis. So it ends up helping with increased insulin secretion from beta cells. Very, very roundabout mechanism. So where glipizide or sulfonylureas have more of a direct beta cell stimulation, these ones work quite differently and almost modulate the body's more endogenous way of doing it and helping the beta cells out. So it's a little bit less thought to be taxing on the beta cells, like the sulfonylureas that are a bit more aggressive with that. A1C lowering is modest, or thought to be modest. However, it does have a pretty good synergistic approach to metformin. The way the drug works with incretin tends to augment the response of metformin. So you end up with a bit of a synergy. So you can maybe get a little bit more bang for your buck than you might think, or maybe you get more out of your metformin that way. So maybe you're getting 1% on metformin. You add a DPP-4, you're up to 1.5% lowering from the metformin because you're augmenting it, and maybe picking up another half from your DPP-4. So a total of 2% lowering. Same thing, just slightly different way of approaching it. They're quite expensive. They're all brand names, so that's an issue. Whereas our thiazolidinedione, pioglitazone, is generic, and our sulfonylureas are all generic too. So those are all cheap. Low hypoglycemia risk, pretty well tolerated overall. The FDA does have a warning out about joint pain. So there are 33 cases over a 7-year period, so not a lot, but it is something that exists, and they did put a warning on it. The symptoms happen 1 month after starting, and they resolve 1 month after stopping. If you actually see this happen in clinical practice, congrats, because there hasn't been a lot of documented cases, but it is possible. So start somebody on a DPP-4, and they end up having sudden joint pain, that's maybe the cause. Linagliptin in combination with medication, an SGLT2 inhibitor, is a recent approved combination. So we're starting to see some of these newer DPP-4s are considered maybe in the newer school of treating diabetes type 2. But we're starting to see these combined with other new drugs to give more synergy. It doesn't really matter other than the convenience, but it is a combo product available. And this has been bugging me. I made a silly pharmacist error here. These are all spelled wrong. They're all gliptins, not gliptans. Sorry about that. All right, SGLT2 or sodium glucose cotransporter inhibitors are listed there. There's 3 of them on the market. This is the newest class of oral medications. These drugs kind of have an interesting mechanism. So they're pretty straightforward. They're basically reducing resorption of filtered glucose. So on average, your body is going to filter a certain amount of glucose per day through the kidneys. And for the most part, your kidneys, you're going to resorb that glucose to retain it. If there's too much, it might filter it out. But what these drugs do is they block that process. So you are going to actually prevent resorption of glucose. Therefore, you're just urinating it out. It's a totally different mechanism of action than anything else we've talked about yet, which makes it advantageous to add this drug on to a lot of different combinations. People might also lose some weight with it. So you actually, just by taking this medication, you probably estimate you lose about 200 to 300 calories per day of lost energy source via the glucose that's getting filtered out. That's about 2 to 3 kilogram weight reduction over 6 to 12 months. So that's going to be somewhat decent for the average patient who's struggling with weight loss and diabetes. This was sustained also through 2 years of research. So it's not like it's an initial thing that they gain back. It does sustain that weight loss. Now the negatives. So renal dosing, you discontinue if not recommended if GFR is less than 60. It's totally contraindicated if GFR is less than 30. There are some, like canagliflozin has data supporting a reduced dose between 45 and 60 mils per minute. That's the only one that has that right now. But pretty much what this means for these drugs, young healthy patients who have diabetes, kidney fit, and with healthy kidneys can take them. Patients with kidney compromise aren't going to be candidates for these medications. And then there's a whole slew of side effects. Hypoglycemia is pretty mild. It is possible. Hypovolemia can cause hypotension and dehydration. This is basically essentially causing diuresis. So that's where you're going to see that happen too. Increases in serum creatinine can possibly lead to acute kidney injury, although that's rare. Increase in LDL is also not a huge deal. The last few are kind of some bigger ones. So ID-related, fungal vaginosis, UTI plus or minus dysuria, and balanitis in men have all been pretty well documented side effects. The reason is, if you think about having urine that's much more rich in glucose than it used to be, that gives any flora in that area a source of food. So you're seeing these increases in urinary tract infections happen with these patients. So in a standard healthy patient doesn't have any real history of it, or if, in the case of balanitis for men, if the male is circumcised, you probably don't need to worry about it. However, I would take caution in patients with history of frequent vaginal yeast infections or frequent UTIs. Probably would avoid the therapy altogether in those patients. Osteoporosis is actually, interestingly enough, is not necessarily contraindication, but I wouldn't give it to somebody with osteoporosis or osteopenia. Data does show that it does increase fracture rates. Why, I couldn't figure out, but that is something that they've seen in some of the preliminary studies going on with these meds. And also there's a twofold risk of leg or foot amputation. So there's that to consider too. Diabetic patients in general have a risk of amputation due to poor blood circulation in their extremities, causing infections like diabetic foot ulcers that end up spreading and need to be amputated. For some reason, this seems to increase that process. We aren't exactly sure why, because you'd think controlling the diabetes would help with that, but it seems to do the opposite. So I'm not sure where that comes from, but that is something they've seen. A1C lowering effects are kind of modest. They fall into line with the rest of what we're talking about as far as the newer agents. So definitely an option, but just keep in mind some of those things. And again, young, healthy patient, good kidneys, this should be a good choice potentially. However, an older patient, bad kidneys. Now, these are new. I didn't put it on the slide. They are expensive too, so remember that too. They're all brand name only. Glucagon-like peptide agonists, or GLP-1s. There's a few products on the market. There's two short-acting products, exenatide and lixisenatide, which are basically irrelevant at this point. The short-acting products just aren't as effective, and lixisenatide has some issues with it as well. So the long-acting products are better, and I listed them there. You'll notice exenatide is both short and long-acting. There's an exenatide ER called Bidurion, which is a brand name. It's just a different formulation of the same drug. So that does work better than your standard Byetta. Byetta was the first drug, GLP, on the market. It's been on the market for quite a while. They come in injectable pens. They kind of look like insulin, and they're injected the same way as insulin. You can't take these orally. They're peptides. And I've got a picture of a Gila monster on there because Byetta was originally isolated from venom found in the Gila monster, and that's how they found that it works to do this, and that's how they discovered the GLP receptors specifically. mechanism anyway. So you get increased glucose-dependent insulin secretion, decrease in appropriate glucagon secretion, and it slows gastric emptying and decreases food intake. So you get some weight loss with these medications as well. Sub-Q injection, these are expensive. You're looking at pretty decent dollar signs, standard biologic pricing, I would say, at like, $1,000 plus a month, something like that. Lowers A1C by 0.5 to 0.5% or to a full percent. So decent results, again, in line with what we're talking about for different drugs here. Dosing schedules are kind of all over the place. Usually you're looking at once weekly or once daily medications, depending on the product. Advantages: weight loss, pretty low risk of hypoglycemia. That's always good. Liraglutide itself has some perceived cardiovascular benefits in some studies, reducing risk of cardiovascular incidence in patients. So that's something that they're currently looking into more of. They might see that indication expand potentially for patients at higher CV risk and diabetes taking this medication. They are renally eliminated, so you do have to dose adjust them appropriately. And they have been shown to see some thyroid tumor rate increases in different animals, I think mostly rats and mice. They haven't seen this at all in humans. However, the FDA did put a warning on this product because of that. So there's that, but it doesn't stop us from using them. It just hasn't translated over into human medicine yet, fortunately. Meglitide are repaglinide or Prandin and nataglinide or Starlix. These medications aren't really used all that much. They're kind of a sulfonylurea substitute. So basically, if somebody's on a sulfonylurea and they're being managed well and they're having some hypoglycemic episodes due to erratic mealtime, you can substitute this in. They kind of work similarly in how they force the beta cells to release insulin. But they have a much lower hypoglycemia risk. So are they less potent? I don't know. They don't really they have an interesting role in therapy, I think, but mostly as a sulfonylurea alternative. So that's why I kind of put them at the end here. They are brand only. They are expensive. Alpha-glucosidase inhibitors. These are delaying hydrolysis of ingested complex carbohydrates. So they're working primarily in the GI tract, which reduces postprandial insulin and glucose peak levels and inhibits metabolism, sucrose to glucose to fructose. They do decrease A1C substantially. However, they do cause some GI side effects that are unpleasant. So for the most part, patients don't tolerate these all that well. So not a preferred option whatsoever. And then we have insulin. So we talked a lot about insulin already. You can use all the type 1 insulins for the treatment of type 2 diabetes. Historically, really, people never used insulin. They always tried tons of oral agents. And then there's kind of some school of thought that maybe we should be using insulin more often. So current practice has drilled this down a little bit more in the guidelines. I'm going to show you how they differentiate this. But for most part, patients who have really uncontrolled diabetes and problems, they like really high A1C, they do recommend basically going insulin right off the bat because it does have much more of an effect on A1C lowering than the oral therapies. The problem is that you can have long-term complications with weight gain with insulin use and also of taxation of the beta cells too. So you can end up with problems with giving insulin and ultimately your beta cells atrophy to a certain degree is how I understand it, and you end up almost over time getting into maybe a type 1 situation where you become insulin dependent at that point, even though it's not autoimmune per se. Okay, so this is, if you go on UpToDate, this is what they recommend. And you can see this is kind of old, so it's they say it's 2017, but 2009 American Diabetes. So this is what they based this chart off of. Go to the UpToDate chapter, and I like UpToDate for the most part. I think they have a lot of good stuff. However, this really doesn't jive with the current sets of guidelines. It's really not as detailed as I want it to be. So basically, it's looking at validated versus less validated. So pretty much it's saying you give lifestyle metformin, which the current guidelines agree with, and then your alternatives, add-ons after that. If that's not working, you add on a sulfonylurea, or you'd add on basal insulin, one of those two options, and then you move on to intensive insulin if that's not working. And they say there's less validated steps where you could add drugs like pioglitazone or other injectable agents, which would be like a GLP-1 agonist, sulfonylurea plus pioglitazone. They don't even have a lot of the new classes on here even. So let's look at the ADA guidelines first. Okay, ADA guidelines. So consult patient, healthy eating, great. Initiate metformin. Again, same thing here. We always want to start metformin, start our lifestyle. That's perfect. And then they say if your A1C isn't achieved after 3 months, add a second agent depending on specific factors and drug characteristics. And they don't really go into details specifically. However, we've talked about some of these. So for example, sulfonylureas and insulin tend to the school of thought is that by giving people these right off the bat, you're going to exacerbate their illness over time. You want to let the body's pancreas work to its natural and full extent. So by giving insulin, it's not going to be able to do that as well. By giving sulfonylureas, you're forcing it to do something aggressively that it shouldn't be doing as aggressively. So with this situation, they're recommending shades of gray here. And I'll show you the AACE, which is much more detailed as far as what they recommend in what order even. The ADA is taking the stance, well, all these drugs work and there's data to support all of them. So really you can go any way on here once you do your metformin. They do also recommend if you're over 9% to start with, you would start with dual therapy right away. So you start metformin plus one of these agents. After 3 months of dual therapy, you go to triple therapy. And triple therapy, again, depends on what you started. So let's say you did metformin and then you're picking which one you did. So that's how they've notated this. So let's say you did metformin plus a DPP-4, and you could add any of these ones on. So basically you can mix and match all of these as much as you want. If A1C is not achieved after 3 months, patient is on triple oral combination, you want to move to injectables, which means insulin, or GLP-1 receptor agonist, you'd add basal insulin. And then it does go on to say continue starting at this stage when blood glucose is really high, or if your A1C is 10 to 12% right off the bat, you might want to consider just going straight to insulin. So if asymptomatic, metformin, basal insulin, mealtime insulin. So that's kind of how they're putting it. So really what they're focusing on is maximizing orals in that 6 to 10% A1C range. Once you get above that 10%, that's where they get more aggressive and say, okay, we need to get insulin on board here. Insulin can lower A1C much more quickly and aggressively than our oral drugs can. It's just some data in school of thought, again, supports that we should try orals first in a lot of patients. So AACE guidelines recommend lifestyle metformin. So they've broken it down based on your A1C. So less than 7%, 7.5%, monotherapy, metformin preferred. If you can't tolerate metformin, they actually give you a hierarchy. So these drugs are in order of how AACE thinks you should use them. So if metformin isn't, like let's say you have a patient with really bad GI side effects on metformin, but their A1C is 7.2, you want to get it below 6.5, you'd give them a GLP-1 receptor agonist. So you go straight to that drug. Even though those drugs are super expensive, patient might not be able to afford them. That's what AACE recommends. Whereas the sulfonylurea, very cheap and also works well, is all the way at the bottom of the list. So very different school of thought than what we were talking about 5 years ago even. Very different. Pushing those sulfonylureas all the way down to the bottom. And basal insulin also not even on the monotherapy. They don't even recommend it for monotherapy. Entry-level A1C greater than 7.5 but less than 9. You're looking at dual therapy, so metformin plus. It's again recommending the GLP-1. Same hierarchy as the other one. They really like SGLT inhibitors. And again, if your patient qualifies for them, great. But a lot of patients aren't going to be able to take them because of a lot of different conditions, kidney disease or UTIs or whatever. So it rules out a lot of people. So you have to remember that. You have to remember the side effects and the medication contraindications. Remember TZDs, pioglitazone, contraindicated in heart failure patients. So think about some of that stuff when you're thinking about how to treat diabetic patients. And then you have the high A1C patients. So if you're over 9, if you have symptoms and you're over 9%, AACE says go straight to insulin, plus or minus your other agents. They're basically saying, give them metformin or whatever else you want, but they need insulin too. If there's no symptoms, you can actually get away with dual or triple therapy. You can probably treat it depending on how aggressive you want to be with it. I'd probably recommend if you had a patient come in and they're 9+, I wouldn't start them on triple therapy. I'd probably start them on dual and then maybe add another one on after that. And then there's triple therapy for general patients. So if you worked your way up the hierarchy, maybe you had a patient come in and they're 7 point, or I don't know, maybe they're 9, right at 9, but they aren't symptomatic. You start them on dual therapy, and then you add on here. So depending on what you haven't added, so let's say you gave them metformin and a GLP-1, well, then you'd go to your SGLT2. Maybe they have kidney failure, or moderate kidney disease, so you're going to go and add your TZD here, or basal insulin. And you can see the hierarchy does switch up a little bit. So when the A1C goes up, basal insulin moves up a little bit in the chart. DPP4s move down. TZDs also move up a little bit too. So you'll notice that there's something consistent about these guidelines, and they really don't like sulfonylureas. And again, a lot of it's that school of thought that they tax the beta cells unnecessarily, and that we have other medications that can work well. We don't need to use them. The big question being is that might be true. These other medications are all really expensive. And I think that's one thing that guidelines, and rightfully so, the guidelines shouldn't be taking cost really into consideration. However, it is something in real life we have to think about. So if your insurance company is not going to pay for these things, you have to have other options up your sleeve. Maybe you're very adamant, you're like, this patient's a perfect candidate for an SGLT2 inhibitor. You need to put them on one. I'm going to fight this insurance company on it. Maybe that's something you call them and you talk to somebody and you explain your rationale, and they might agree with you. They may say, nope, try this first. So it's something you're going to encounter in your practice is you might have a therapy that you think is best for the patient, and maybe it is, and you have a justifiable cause, but you might have to justify that to insurance company. And at the end of the day, if the insurance company still doesn't want to pay for it, you might have to justify that to your patient and say, I want you to pay $300 a month out of pocket for this medication because it's the best one for you. It's going to work better than this drug. And maybe your patient can afford that, and maybe they can't. And that's where you have to be flexible when it comes down to this. So that's why I think both these guidelines, pretty similar message overall. Think about it as metformin starting, adding on, going to triple therapy if you need to. You can really mix and match all these classes to your heart's content. AACE gets a little bit more detail oriented as far as hierarchy and which ones they prefer, but in actuality, there's no great evidence to support what ACC is saying. I mean, they're making that based on evidence, of course, but it's not like ADA is wrong in saying we're going to say, well, all these are okay. They all do slightly different things, and you should pick based on your patient, based on what your patient needs. Like, if your patient has a total fear of needles and doesn't want to inject, you aren't going to force a GLP-1 agonist on them. You go to another oral agent. So think about those types of things too. But I do think both guidelines are great framework for how to approach a diabetic patient. I think they're both pretty successful, but it doesn't make it easy. So the question is, when you're treating a diabetic patient, and for my exam, how am I going to test you? My questions will be based fairly traditionally, so I'm going to focus on things like starting patients on metformin and when to do basal insulin. So like I might give you a really high A1C, like say they're at 10 or 12 or just something really high. So I would know the A1C stratification for my exam. So if I gave you like 10 versus 7.5, would you be able to know, okay, 7.5 patient would be fine with metformin. 10 or 12 patient probably needs insulin. Now where we get in the middle, I'll probably give you a case that might have certain criteria that they meet. So maybe I give you a patient on metformin who's younger, healthy, that would probably clue you into a good candidate for an SLGT inhibitor. I can never say that. I think I always say that wrong. SGLT. I always want to say SLGT. Sorry. Or DPP4s are good synergistic agents to metformin. So maybe I give you a patient who has some kidney compromise and they're on metformin. DPP4 might be a good second line. Maybe I give you a patient who's on a DPP4 and metformin. And you think about those things. So think about the criteria behind the drugs and which are absolute contraindications. So obviously you're never going to give an SGLT2 to somebody who's got kidney failure. You're never going to give a TZD, a thiazolidinedione, to somebody with heart failure. You're not going to give a GLP-1 agonist to somebody who I tell you has no interest in injecting anything into their body at this point. Same thing with insulin. You aren't going to give that. You're going to go straight to insulin in really high A1C patients. You're going to do metformin monotherapy in people who have just slightly elevated A1C. So it's really important to understand those nuances. And I think the guidelines, while they hierarchy things differently, pretty much get to that same conclusion that I'm giving you here. So while what I'm trying to say is that you don't have to know the guidelines per se, I'm not going to say based on the AACE guidelines which one would be the preferred hierarchy here. I don't care that you know that because I don't think it necessarily matters in real life per se. However, I do expect you to know generally what the strategy to approach treating a diabetic patient is. So I think my questions will make sense regardless of which guideline you look at. So with that being said, we're done a little early today, so it's only about an hour and 20 minutes, which is great. It's a ton of information and a ton of new drugs, and it's complicated because they all have different acronyms. I have trouble with these medications, I'll be very honest, because I think about DPP-4. I'm like, okay, is that a gliptan? Is that a what? You really have to go through this a lot to get it into your head. And I really do think it's important to understand all these acronyms. Normally I'd say, well, just understand like one drug in each class, but I do think it's important. The nice thing is that most of these medications, if we go back to some of them, like very similar naming things. So you just really need to associate the suffixes of the medication with the class. So know that a GLP-1 agonist all end in glutide, and then any drug you see on my exam that ends in glutide, you'll know exactly what that means. So that's where I'd recommend studying. That's how I personally remember them. SGLT2, same thing, they all end in flozin or gliflozin. Very recognizable name there. So as long as you can put those two and two together, then you can associate that grouping with the different side effects. And then same thing with DPP-4, all end in gliptin. So just go through these and spend some time on them. I really do think it's important, and I think it's very important for pretty much any practice standard to have a good understanding of diabetes. So with that being said, if you have questions, let me know. Otherwise, I'll see you in class next week. Thanks.